Hey, and on This Week in Pharmacy, I'm here in the Brownsville studios, Brownsville, Pennsylvania. If you don't know where Brownsville is, look that up. And I'm excited to have a guest in the studios today with me, Rob Maher. You are a legend pharmacy owner here in Western Pennsylvania, Southwestern Pennsylvania, out of the Pittsburgh area. And I remember back in the day how you and Sean Nairn were running hometown pharmacies and things like that. And you had Mission Pharmacy, which was a long-term care organization. And talk to our listeners about who you are and what you do in pharmacy.
Sure. My name's Rob Maher. I've been a pharmacist for 30 years. Actually grew up in pharmacy. My father had a pharmacy, started in 1974. So I always like to say, yes, I've been a legal pharmacist for 30 years, but probably been hanging out in a pharmacy since I was old enough to walk. So been a pharmacist a long time. Had the opportunity to have many different lives in pharmacy. That's what's the beauty about this profession. Thought I was going to start out in community pharmacy, and I went back home, but I ended up getting a job at a hospital along with working with my father, and kind of got a clinical bug. And I went back to school, and I graduated from the University of Pittsburgh in 93, worked 2 years. But and during that 2 years, I said I worked at a hospital and worked with my father. But we also at that time had a long-term care company, not Mission, but it was a different company. And I had a pharmacist who was a consultant, and she got me into that clinical bug. So I went back to Pitt in 95 and had a awesome experience. And while I was doing my experiential rotations, I learned that there was residencies in geriatrics. I had an interest in the elderly. And so I had an opportunity to do a residency down in North Carolina at the Duke Center of Aging and the Durham VA. And it was there that I had my first experience of what pharmacists could do if they're working with other healthcare professionals. And during that time, we worked in a physician practice where the first person the patient saw was the pharmacist. And we were doing med reviews, med recs before even the term MTM came out. And so when I came back to Pittsburgh and got into teaching at Duquesne University, I was first put into a hospital setting for my clinical site. But I kept seeing that, all the problems that are happening to these patients are bringing them into the hospital are occurring in the community sector. And that's kind of where I went back to community pharmacy. And in that time, Sean Nairn, my father, David Sipple from Klingensmith, and a group of others started a company that was putting pharmacies in grocery stores in shop and saves, and they were called hometown pharmacies. And I started putting students there. We actually got a residency, and our goal was, what else could we do to help patient care in those areas? And that's kind of where it got started. Also, during that time, we had a long-term care pharmacy where I ended up running that for 6 years. And like I said, we were all partners, various different shares in that company. And then eventually we kind of, nothing negative, we kind of just went our own ways. And, Sean went on to start Acor, and I went on to working with my father more, and also working with Klingensmith. And that's kind of how I got involved when PPCN was first starting. And what I love about what the Pennsylvania Pharmacists Care Network is how can we get community pharmacists paid differently to be able to do good patient care? And over the years, I've worked with them as I was the director of pharmacy services at Klingensmith. And now I have the opportunity and honor to take over for Brandon Antonopoulos, who started his own Cost Plus Pharmacy back this past spring. And so now I'm the president and chief operating officer, and excited to be here because I truly believe community pharmacy is where it starts. We're on the front line. I think, that we can partner with our colleagues in the ambulatory care setting, the hospital setting, to help deliver good patient care. So that's my story in a very short capsule. And what I also do is I also teach part-time at Duquesne University. I teach pharmacy management. And if you had told me I was going to teach pharmacy management 30 years ago, I would have laughed, because my first realm was clinical. I used to teach asthma, COPD, and also geriatrics, but now I'm the pharmacy management teacher.
That's great. It's exciting to see the transition and also the reinvention, because that's what the entire profession is going through right now. And if you didn't have an opportunity to see different things grow, transpire, and then either be sold off or go to the next phase of your career, it for our younger pharmacists, for our pharmacy students listening in, you may think, oh, there's a lot of unstableness in the industry right now, and we're seeing a collapse. 7,000 community pharmacies closed over the last 2 years, so they're probably scratching their heads saying, do I want to be here? Do I want to be in this profession? It's not that profession anymore. It's not the 20-year ago profession. It's the 2024 version. It's the future profession. But the purity of what community pharmacy does for the community in and of itself as a healthcare hub and public health overseer and protector and advocate, patient advocate, you saw that when you were building out Hometown. And it was interesting you called it that, because it literally was in the Hometown pharmacy right there in your grocery store, which that's not even thought of the way that you thought of it isn't even being utilized in some of these major grocers. They're using pharmacy sometimes as more of a commodity or a draw in, not realizing that it could become a profit center if they started doing other things that weren't necessarily attached to the dispensing side of it.
Yeah. And just to build on that, we actually do have a small chain group of grocery store pharmacies that are part of our network, and I'm very appreciative of them because they do get that. And one of the things you brought up a good point, that it is changing, and there is unfortunately a lot of negative things that have happened in the industry.
Of course.
But there is some positives. There's some hopes. We did have here in Pennsylvania this past year, and just recently, our bill passed for 1993, and thanking the governor and Jessica Benham and all our representatives for getting that passed. But it's just the start. But I think the other thing that is actually very exciting is, for the first time ever, pharmacists have the opportunity to be Medicaid providers. And that can happen right now. And that is one of the things I believe our network can help for pharmacists do, is to get into that space, because we have been doing that already with our current Medicaid managed care contracts that we have. But one of the things that I think community pharmacy can do, and it's been doing it, since the beginning, but I think because we were tied to our business model to a product, we didn't really look at the opportunity we could be doing with affecting outcomes. We were always affecting outcomes, but now we're looking at it in a way that this is our business. This is what we do. We see patients 35 times more than in any other sector community pharmacy does. And we see those patients every day, and they have trust in us, and we have those relationships with them. So this opportunity, although there is, as you said, some negativity in the industry, those who want to take advantage of this opportunity, I think, can have a good, successful business if they start embracing this model, which I like to say is we are putting services around that dispensing model.
Yep.
We are still the access, we are still the safety measure to take care of patients when they get their medications, but we're also there to make sure that they know why they need to take that medication, that they're adherent, to identify if they're having any problems with that medication, and relaying that back to the physicians. Because I'm not going to get political here, but when we look at healthcare, medicine costs always bring to the forefront, but the biggest cost is hospitalizations, ER visits, and overutilization of unnecessary visits. And a lot of that stems if somebody's not taking their medications appropriately. And that is what our network really helps focus on. And that's why we partner with payers, so we can, give them pharmacies that are in those communities that are on their health plans to make them healthier, to prevent those from occurring.
I love that. I love that. Rob, I want to back up for just a second. I do want to say this to our listeners. Pharmacy is extremely political. And I'm going to give you an example. The patient's advocate of medication safety, medication management, and best utilization of those specific medications, as well as the pharmacological and all the nerdiness that you pharmacists understand. You are the advocate, you are the politician for that patient. You are literally, we hire our politicians, and sometimes they do a horrible job and sometimes they do an okay job. Governor Shapiro, by the way, clap to you. Thank you so much for signing that bill and for listening to your House, listening to your Senate, listening to the people, and moving forward based on the insiders, because he got to listen to insiders of the industry. So the reason why I want to make a point about politics, because we're in a political firestorm right now from a national level, but you are, and that is you pharmacist and even you technician, you're listening right now. You are the politician for the patient's health. You have an opportunity to speak up for that patient and take a stand and say, the way that my tax dollars being used to help these people live better lives and healthy lives is not being used. And that should anger you. That should make you mad that you're like, wait a second, the money that's out there in tax, the money that's out there in just private funding, regardless, that money is supposed to go towards the health of people. People's lives are at stake, and it's being sucked up in the form of profit. And that's what everybody that thinks of getting awards of this and this and over here from a media perspective. And listen, the entities, the organizations, the PBMs that are doing what they're doing, they have some wonderful, wonderful people that are passionate about what they do inside those companies. The pharmacists, for example, the techs, the people. But that's not the issue. It's the it's the boards of directors who are making major decisions about how to move forward, and where the funding was supposed to go towards patient care, it went straight to their pockets in the form of
and that's why there needs to be regulation in that area. And as I talk about change and being paid differently, we still have to fight that we are being paid fairly, or we still can't keep our doors open. And you're right. The middle person, there are, a lot of times the word PBM sounds bad, and that's because we have 3 bad actors right now that aren't there. There's no rules for them, so they can use that to their advantage. There are some good transparent PBMs out there that are doing excellent jobs. And just like every industry, if you don't have rules and regulations, and granted, I know there's times where we can over-regulate, but if you don't have rules and regulations, the system's going to happen. And you're right that, I liked your term that we are, political advocates for our patients. And I believe we are. We didn't, I always hear stories about people about what they did during COVID and when they were at home, and they asked me, what did you do? And I said, I never was home. Mm-hmm. We were always in the pharmacy. We were there. We didn't close our doors. We made sure patients got their medicine. And that is, you made a good point. And that's what I think like our network can do for people, is it helps bring in other ways to bring in fair revenue to be able to stay open. I also think that we are partnering with the real healthcare professionals, and that is the physicians, the hospitals, the health systems, so that we are improving the overall health of our patients. So,
and I want to give a shout out to our payers, these wonderful organizations that are trying to work better with pharmacies. And just like you said, Rob, there's in every industry that has humans involved has bad actors and good actors, and they have bad actors that see their errors of their ways and they become good actors. That's just human. I'm an jerko, or we can say, wait a second, the swear word we can say is jagoff, because it's a Pittsburgh term.
You got it.
And you can be a jagoff. You person listening right now, you are probably a jagoff once in a while, and then you turn around and you correct it. And We're all humans. So I'm not saying doomsday, PBM, horrible organizations, but I am saying the way that things are right now, we can't sustain it. Our population, they say, over the next 5 years is going to hit 345 million. We have 300,000 active pharmacists. Do the math. And then we have 7,000 less pharmacies in the entire country. Do the math. I mean,
Yep.
it's not a
Yeah.
this is a public health issue, and the politics should be, is this helping patient care? It's a yes or no question.
Yeah. And then you remind me of a story that from when I was going in my residency, and give me about a minute, and there's a point to this, is when I was going to interview at Duke, I didn't get an agenda. I didn't know who I was meeting first. And when I got there on the agenda, the first person I was meeting was not a pharmacist. It was Dr. Harvey Cohen, who was the head of the geriatric department, both for the Duke Center of Aging and for the Geriatric Research Education Center at the Durham VA. And I was like, I'm 20 some years old, real nervous. And he looks at me and he says, "Rob, do you like sports?" I said, "Yeah, I love sports." He goes, "Do you love basketball?" He goes, "Do you like basketball?" I said, "I love basketball. I played basketball. I'm a diehard basketball person." He goes, "What's the most important, word in basketball?" And I said, "Team." And he said, "Exactly." He goes, "I'm the physician. I got lots of knowledge, but I'm only as good as the team around me." And that includes the nurse, the pharmacist, the physical therapist, everybody that is working around that patient. And I think we become a better health system when we get back to that, that the community pharmacy is just as important as the physician's office, as the hospital, and we communicate. In a perfect world, and this is my last point of that, wouldn't it be great that hospital, the pharmacy needs, the clinical pharmacist contacted the ambulatory care pharmacist who works in the doctor's practice, and then that ambulatory care pharmacist knew that community pharmacy in that patient's neighborhood that is going to help deliver what needs to be done, and that communication goes back and forth. How much healthier would somebody be if that communication happened every day? And it does happen in different pockets, but I think that's what we should focus on, whereas we're so focused on, the middle persons and we need to have regulation on them, but we need to start from the beginning. How do we make this system work and tell the payers this is how it's got to work?
Yeah, it's TogetherRx. I believe in the whole concept of the quarterback as the play begins, the play that you've already designed, the treatment program play. When you snap the play ball and that ball goes to the quarterback, our physicians, and they get to determine the running of that play. And then they pass that treatment to the pharmacist, or they expect the nurse to block for them and get, some of the issues that they're going to experience of getting tackled by, so many issues, even clinical issues, germs, for God's sakes, pre-authorizations, insurance claims. I mean, it's the play, the ball, the patient. We're taking that ball, that patient that is the ball, to the goal line in order to get them the care that they deserve. And so I love that team approach. It's the whole concept of what is TogetherRx. That's exactly what it is. It's collaboration. It's the way that medicine is supposed to work. And you can drive it by pharmacy as the hub, because pharmacists are being accessed 9 times more, for goodness sakes, than their physician every year for the population. So use that to your advantage. It's not a turf war. It's hey, the patient needs this. Let's get it done.
And as we push for more legislation down the road, or more change in regulations to help the pharmacist do what they need to do in the community, such as being able to do testing, such as, we have the ability right now to do strep and flu and COVID, but the ability to do simple testing like hemoglobin A1Cs, that if we can get those, ability to do that, we're not stepping on the turf of the physicians. We're helping enhance something, because there's a patient out there that may not ever go to their doctor, and you discover they have this high hemoglobin A1C, or you discover they have this high blood pressure. that referral back to the doctor or convincing that person they need to go to the doctor. I can't tell you how many times I have family members or friends where they say, hey, I have a question and a problem. And they don't always like when I give them the answer, you really got to go to the doctor.
Yeah.
And well, isn't there something I
They
can
wanted
just
a quick
buy?
fix.
Yeah. Isn't there something I just buy? No, you really need to go to the
Yep.
doctor, and you really need to go get this additional test.
Exactly.
But let's test your blood pressure first and see where you're at. So that's where I think sometimes our organizations get very narrow-minded, and we get these turf wars thinking that, oh, pharmacy can't do this. Oh, nursing can't do this.
Yeah.
There's no, I respect every physician. I have good friends that I grew up with. I have a friend back home who has his own family practice. And I can't tell you the relationship we had. And, if I had a question or there was a problem with this patient, I text him. All right.
Exactly.
And I said, hey, are you in the office or are you on call? This is very important. And he would call me, or his physician assistant would call me. That's the relationships we're talking about.
Well, Rob, this has been an awesome time to be able to share with you. I want to give a shout out to our listeners. If you're not watching us on YouTube, I want you to take a look at PAPharmacistsNetwork.com. That's PA, stands for Pennsylvania, PAPharmacistsNetwork.com. Rob, promise me that you're going to be back in the studio. You're going to bring us more interviews and more content about what's happening in the trenches in pharmacy care, and just be part of this again.
Yes, I'll be happy to. So thank you for having me here today.
And thank you for listening to This Week in Pharmacy. And we hope you guys have a great week. And if there's anything that the Pharmacy Podcast Network can do with you, for you, collaboration, let us know. Peace out. Together, RX.